Hello, everyone. My name is Dr. Samir Parikh, and I'm a nephrologist at The Ohio State University. And I'm going to spend the next few minutes discussing how we define treatment goals in lupus nephritis. My disclosures. So what are the treatment goals for lupus nephritis? So when we think about how we're going to treat lupus nephritis and what we want to achieve, or what we want our patients to achieve with treatment, is three main things. The first is the idea that we want to achieve a rapid disease control, or what we call remission of active disease. In doing so, we want to be able to prevent long-term organ damage. And ultimately, and probably most importantly, we want to improve disease-related quality of life. So how do we achieve those things? There's about several things that we need to think about. First, we want to achieve a rapid remission of active lupus nephritis, and when we do that, that will help reduce morbidity and mortality. It'll allow us to preserve our long-term kidney function, improve patient survival, reduce risk for cardiovascular disease, and then after we achieve rapid remission, we need to not only achieve remission, but maintain remission, prevent kidney flares. In doing that, will also help reduce morbidity and mortality and improve patient survival. Finally, as we do this, we're preventing organ damage, and we're hopefully improving patients' disease-related quality of life. So which definition of complete renal response is the best predictor of good outcomes? The usual definition of renal remission includes proteinuria level of less than 0.5 grams per day, and that's according to several different guidelines, though different criteria have been used across clinical trials. And to date, there is not one definition of complete renal response that is consistent across the guidelines and based on evidence. So whether the cutoff of proteinuria level of 0.5 grams per day is the best predictor of long-term clinical outcomes was a question of study. And there are two analyses of patient cohorts that looked at this. First, your lupus nephritis cohort of 76 patients and the maintained nephritis cohort of 90 patients. All the data was collected prospectively, and they looked at 1-year clinical markers to determine 10-year outcomes. So they basically wanted to understand which clinical markers at 1 year best predicted outcomes at 10 years. And what they found inconsistently in both studies was that proteinuria level of less than 0.7 or 0.8 grams per day was the best predictor of good long-term renal outcome in both studies. Hematuria, creatinine, they did not add to these prediction models. It was proteinuria alone as the best clinical predictor of long-term outcomes. So achieving renal remission is critical to maintaining long-term kidney health in lupus nephritis. And there have been several studies that looked at complete remission versus non-remission and what are the outcomes in lupus nephritis. And this was a nice study done that looked at 86 patients and looked at complete remission, partial remission, and no remission at 5 years, and followed them for 5 more years to see what their overall patient survival and renal survival was. And as you can see by the figure here, that in patients who achieved a complete renal remission, they did really well over the 10-year period with 92% patient survival and over 90% renal survival. In partial responders, they did better than those who did not respond, but still had a significantly less patient survival and renal survival compared to those who achieved a complete response. This just highlights the extreme importance of achieving an early and complete and sustained complete remission to preserve long-term kidney health and improve overall patient survival. So when we talk about sustained clinical remission, what we mean is that we don't just want the patient to achieve a remission from the initial treatment phase of lupus nephritis. We want to make sure that we preserve their organ health by preventing relapses and flares down the road. So in patients who achieved a sustained clinical response for at least 5 years, they were compared to those who had clinical response for less than 5 years, and the key metrics, hard metrics of outcome, were compared. And as you can see from the hazard ratios in this multivariate analysis, those who achieved a complete and sustained clinical remission for at least 5 years had significantly lower risk for death, damage, end-stage kidney failure, reduction in GFR, and doubling of serum creatinine. And when we think about preserving kidney health and prevention of chronic kidney damage, of course, we want to make sure we prevent the progression of chronic kidney damage just to preserve the kidney health itself. But there's another factor that's really important that we need to discuss, and that's prevention of cardiovascular disease. So patients with lupus we already know they're at significantly higher risk for cardiovascular disease, 9 to 20-fold higher risk compared to the general population. But we also know independently that patients with chronic kidney damage at every level of chronic kidney damage are at significantly higher risk for cardiovascular disease. So as shown in the figure to the left, you can see patients who have no CKD, as shown in the figure in bar graph in black, compared to those who have CKD stage 1, 1 and 2, 3, or 4 and 5. And with each level, there's a higher risk for cardiovascular disease compared to the other level, and significantly greater at each level compared to the general population. So when we look at this in the setting of lupus, in patients who already have higher risk for cardiovascular disease, if we want to improve patient survival, a key metric here in patients who develop lupus nephritis is to achieve and maintain early remission, because we want to prevent long-term organ damage, which will increase their risk further for cardiovascular disease and reduce patient survival. So the traditional treatment approach to lupus nephritis involves the use of high-dose corticosteroids in addition to steroid-sparing agents. And historically, these protocols have been used because steroids are potent anti-inflammatory therapies and are effective in controlling and suppressing inflammation. However, steroids are also associated with considerable long-term treatment-related toxicity. And recently, there have been steroid-sparing protocols that have come online that have demonstrated similar efficacy to the traditional approach with high-dose steroids, but with less or even no maintenance oral steroid use during the induction phase of treatment. This is just one of several protocols that have come online recently that have demonstrated an ability to or have shown us and taught us that perhaps lower corticosteroids can be used and without impact on achieving disease remission when we're applying therapies for lupus nephritis treatment. So what about recurrent flares? So having a flare is a concern, needs to be controlled, but then maintaining remission is also very important, as we mentioned, to help prevent rapid kidney damage. So this is a graph that's looking at nephron loss. So in patients in the green bar from aging alone, and you can see that after the age of 40, and even after the age of 40, basically we lose about 1 ml per minute per year as part of aging, and that's just normal nephron loss. However, in patients who have lupus nephritis, in a single episode of lupus nephritis, you can see the nephron loss is significantly more substantially greater, although this is not terribly unexpected. But if we're able to control the disease, then perhaps we can get back to a slower rate of nephron loss over time. Meanwhile, if we don't control the disease, of course, nephron loss occurs at a much greater rate. And just even a few percentage points here of change can mean all the world to delaying dialysis or need for transplant by 5 to 10 years. So patients with good kidney outcomes spend less time in kidney flare, and of course those with poor kidney outcomes. And in a study that was done by our group looking at median time to flare and risk for chronic kidney damage, what we found was that patients who spend at least 30% of their time, greater than 30% of their time in renal flare from the time of diagnosis, were at higher risk for developing incident chronic kidney damage and progressive renal failure. And this was found to be an independent risk factor for progressive renal failure in this patient cohort. So again, just reinforcing the idea that not only do we need to control the flare when it presents, but we need to maintain remission and prevent recurrent flares to achieve good long-term prognosis. So let's summarize what we just discussed. So in lupus nephritis, our major treatment goals are to achieve a rapid remission, and in doing so will help prevent long-term organ damage. There is a significant need for consensus definition of renal remission. Our current definitions have affected our clinical trials in terms of the metrics that we use for response, and perhaps we're being too strict with the proteinuria goals for clinical remission, as has been shown in recent studies. Prevention of renal flare is critically important to improving patient survival as well as organ survival, of course. And so not only is it important for us to induce remission of the flare, but also prevention of relapses is critical. And it may be possible to achieve remission in lupus nephritis while minimizing the use of steroids. And there are certainly steroid-sparing regimens that are coming online now and have been shown to be effective in clinical trials. And perhaps we can leverage these steroid-sparing regimens to limit the steroid use for treatment of lupus nephritis. And ultimately, with the most important goal of all of this is to reduce treatment-related toxicity. And ultimately, when we see a patient with lupus nephritis, we need to consider the entire picture. So lupus nephritis is specific to the organ, but lupus is a systemic disease and we need to treat it as such. Importantly, as we identify more biomarkers and newer treatments, our treatment approach to patients with lupus nephritis may become more personalized. And this is where the field needs to move. But still, we don't need to wait for new biomarkers or a whole armamentarium of treatment. We treat the patient in front of us and create a treatment plan that best suits them based on the existing data that we have, and we do this together with the patient. And so that is our our goals for lupus nephritis, and ultimately, in doing so, we'll have improved quality of life, and hopefully we'll reduce organ damage and preserve long-term patient and kidney health. With that, I'll conclude, and I thank you for your time.